Hello, my name is Aaron Petra. I'm a physician assistant working at the Institute for Minimally Invasive Spine Surgery in Holyoke, Massachusetts. We operate out of Holyoke Medical Center with our attending neurosurgeon, Dr. Pennings, and today we're going to be talking about multimodal pain control. So a basic overview of pain control. After any type of surgery, patients can experience pain. This can be related to the trauma of surgery, but can also be related to swelling and inflammation that develops after surgery. The best way to treat postoperative pain is with multimodal pain control, meaning multiple different pain agents. Usually we start with over-the-counter medications and then advance to prescription muscle relaxers, nerve pain medications, or narcotic pain medications. So reducing pain with a minimally invasive approach. As you can see on the right-hand side, there's an incision example of a minimally invasive spine incision. And on the left-hand side, we see an example of an open spine incision. And just looking at the size of the incisions, you can imagine there's much less trauma that occurs based on how the procedure is opened. In keeping with our minimally invasive approach, on the right-hand side, you see an example of a laminotomy defect, which we typically will perform when doing lumbar decompression or microdiscectomy surgeries. On the left-hand side, you see an example of a laminectomy, which is typically performed during the same surgeries if the procedure is done as an open or traditional spine surgery. And looking at the amount of bone and the amount of tissue removed, it's clear that the open spine surgery would create much more trauma and therefore much more pain. For preoperative pain control, patients are given medications before surgery that can help prevent nerve pain after they come to the hospital the day of surgery. These include nerve pain medications, muscle relaxants, and other pain control agents. Examples include gabapentin, methocarbamol, and acetaminophen. For postoperative pain control, our first line always starts with over-the-counter medications. It's going to be a common theme throughout this presentation. We encourage most of our patients to take Tylenol or ibuprofen as long as they can tolerate these medications and don't have any contraindications. For Tylenol, we typically recommend 500 milligrams every 4 hours for the first week after surgery. And for ibuprofen, we typically recommend 600 milligrams every 8 hours for the first week after surgery. More detailed instructions are provided on a case-by-case basis in your discharge paperwork, so please defer to that if you are having surgery with us. For postoperative pain control, we'll start with our transcambin lumbar interbody fusion. For different types of surgeries, patients will be placed on different medications. For transcambin lumbar fusions, we access the disc space via Cambin's triangle, as pictured to the right. And as you can imagine, sometimes there is a low-grade burn or irritation to the nerve that we pass by in order to do this type of fusion. So occasionally patients will experience one-sided leg pain on the side that we did surgery. This typically self-resolves within a few weeks after surgery, but we do provide some extra medications listed at the bottom which help with this pain if it does occur. For our other types of fusion, including oblique lumbar interbody fusion and transforaminal lumbar interbody fusion, we typically suggest starting with over-the-counter pain control. If over-the-counter pain control is not enough to control the pain, so things like Tylenol or ibuprofen don't provide enough pain relief, we do prescribe narcotic pain medication for breakthrough pain, and we'll also occasionally prescribe muscle relaxers or nerve pain medication. However, it's typically not needed. For our cervical, thoracic, and lumbar decompression and discectomy surgeries, we again recommend first-line treatment of pain with over-the-counter pain meds. We do routinely send in narcotic pain medications for breakthrough pain or flare-ups of pain. But typically muscle relaxers and nerve pain agents are not needed due to the minimal amount of trauma sustained during these types of surgeries. For anterior cervical discectomy infusions, and also for our total disc arthroplasties, we typically prescribe lower dose narcotics than our lumbar fusion patients, as there's much less trauma and much less overall inflammation and swelling related to these surgeries. So we encourage over-the-counter pain medications and the occasional narcotic pain medication if needed. For flare-ups of lower neck or mid-shoulder pain, we do occasionally prescribe muscle relaxers as well. Other conservative options that we typically recommend are things like lidocaine patches, which may contain camphor or menthol. These are fine to use, but we ask you don't put them near the incisions. Pain gels and creams are often very helpful as well, but again, we don't want them near the incision so the incision can heal properly. And many of our patients find good relief with ice and heat, as long as ice and heat is not applied when it is wet. We don't want the wound to dehisce or open up, so whatever substance the ice or heat is put into, such as an ice pack, needs to be dry so it doesn't wet the wound. And a note on the bottom, if you're using lidocaine patches, we ask that you observe the 12 off and 12 on rule, meaning you can wear the patches for a 12-hour interval, but we ask that you take them off for 12 hours to give the skin a break, otherwise it may desensitize and will not provide pain relief. That is our overview for multimodal pain control for the Institute for Minimally Invasive Spine Surgery. Please feel free to make a follow-up appointment or call our clinic if you have any questions regarding this presentation. Thank you.